This is the second part of the lecture on the anatomy of the lungs and respiration. In this section, I will describe the lungs. My name is Carlos Andres Suarez-Quian. I am the creator and narrator of this lecture. Let's start. There are several objectives in this lecture, and they're listed here. I will not read them to you, but feel free to stop the film and read them by yourself. Previously, I showed you this image while describing the respiratory tract. The lungs have been removed from the thorax, and I was showing you their costal aspect. Let's look now at the lungs from the mediastinal aspect. Inspired air will travel down the trachea and enter each lung by way of bronchi. The lungs represent part of the lower respiratory tract, and it is at the lungs where gas exchange occurs. The lungs are indeed the culmination of the lower respiratory tract. If I now zoom in on the lungs, the primary bronchus of the right lung can be seen to be wider and straighter than the one on the left. As with the trachea, the bronchi are partially surrounded by cartilages to help keep them open. Of clinical relevance, if a child inadvertently inhales a small object, the probability will be greater that the object will end up in the right primary bronchus if the object makes it all the way down into the lungs. Each primary bronchus will give rise to secondary bronchi, 3 in the right lung. Note the lower secondary bronchus on the right is partially obscured, and 2 in the left. And these will continue dividing and becoming thinner in diameter as tertiary or segmental bronchi. Here's another example of dissected lungs. The right primary bronchus extends into 3 secondary bronchi, whereas the left outspreads into only 2. The openings of the secondary bronchi are better visible if I zoom in on the image. Air entering the bronchial tree from the upper respiratory tract is only part of the structural equation required to deliver oxygen to the body. The delivery of oxygen, as you're likely aware, occurs by way of the circulation involving the cardiovascular system, now indicated in, yes, this very complicated image. Let me label some other relevant structures. Note that you're looking at the thoracic entryway from above. The right side of the heart is at the left of the image, the left side at the right side of the image. The anterior of the entryway is indicated by the sternum. Posteriorly are the vertebrae, and recall that the esophagus runs posterior to the heart. Additionally, the right ventricle and the right atrium of the heart are visible. Venous deoxygenated blood enters the right atrium by way of the superior vena cava, the SVC. The inferior vena cava is not visible from this view. Blood will travel from the right atrium to the right ventricle, and then the deoxygenated blood will exit the right ventricle by way of the pulmonary trunk and then travel to the lungs. The definition of a vessel being an artery or a vein is to whether it carries blood away from the heart or to the heart, respectively. Hence, the pulmonary trunk is an artery, albeit one that carries deoxygenated blood. Once the blood reaches the lungs, it will be oxygenated and returned to the heart by the pulmonary veins. Finally, oxygenated blood will exit the heart to reach the rest of the body from the aorta. Let's now continue our examination of the lungs and see where actual gas exchange occurs. Understand, however, that you will receive much more detail about lung histology in a microanatomy course. On the left of the image is a dissection of isolated lungs, and on the right is a drawing of the microscopic field where the exchange of gas occurs in the lung. Microscopic examination reveals that each segmental bronchus observed with the naked eye defines a bronchopulmonary segment. Within a bronchopulmonary segment, the segmental bronchioles branch into numerous respiratory bronchioles that ultimately terminate into sac-like structures. These sac-like structures are called alveolar sacs, and each consists of numerous individual alveoli. Let's now focus specifically on one of these bronchopulmonary segments and examine how arterial blood and venous blood circulate through a segment within the lung. And the first thing we observed is that the segments are true tissue segments with their distinct boundaries. Indeed, the existence of these boundaries has been known since the 19th century and were used to induce segmental pneumothorax to try and alleviate the symptoms of tuberculosis. I will talk more about this later. Also, the presence of segmental boundaries is now exploited in the surgical management of lung cancer in the absence of metastasis, in that a localized bronchopulmonary segment can be excised without the need of removing a complete lung. As to how blood is oxygenated within the lung, this is what happens. Blood from the heart is delivered to the lungs by pulmonary arteries as discussed above. The blood reaches the alveolar capillary plexus, and it is here that the inspired air can diffuse into the capillary plexus to eventually be entrapped by the red blood cells and enter the circulation. In turn, the carbon dioxide is released back into the alveolus for expiration. Note, this explanation is completely devoid of the physiological events that occur at the microscopic level. This is a topic for the discipline of physiology and will be discussed in that course. The oxygenated red blood cells now leave the alveolar capillary plexus by way of the pulmonary veins, now shown in red. Our story of blood circulation through the lung is almost complete, but not quite. The lung tissue itself, the parenchyma, as with any tissue in the body, also requires its own oxygenated blood supply, and this is brought to the lungs directly from the aorta by way of the bronchial arteries, branches from the aorta. And note that these arteries need to deliver oxygenated blood to all parts of the lungs. Hence, there will be various entry points into the lung parenchyma. The pulmonary arteries are colored red within the bronchopulmonary segment. Since we need bronchial arteries, we also need bronchial veins. But note to where the venous return of the bronchial veins occurs, to the pulmonary veins. Hence, the pulmonary veins do carry some deoxygenated blood back into the heart circulation, albeit the amount is small and inconsequential. And now, to complete the picture of the anatomy of fluid circulation in the lung, we also need to mention that the lung will generate lymph, and consequently, there too will be lymph vessels in the lung, shown in green, that travel with the pulmonary veins and bronchioles draining to the right and left bronchial mediastinal trunks that will drain to the deep veins of the neck. And here's a sobering thought of how knowledge of the existence of bronchopulmonary segments was exploited in the treatment of tuberculosis, or consumption as it was known back in the 19th century. Between the 19th and 20th century, prior to the development of antibiotics, it is estimated that 1 to 2% of entering medical students would die of tuberculosis before graduation. An anatomical basis for treatment of tuberculosis was to induce a therapeutic pneumothorax and allow patients to rest the afflicted bronchopulmonary segments at a sanatorium. The rationale for this treatment was that the mycobacterium bacteria is aerobic and depletion of oxygen would halt its morbidity. Understanding the anatomy of the lung also helps to explain how respiration is impaired during the common disease of asthma. If a section, indicated by the hatched yellow line, is taken from a lung and the bronchioles examined with a microscope, a normal-looking bronchiole can be observed. As the bronchiole becomes smaller, it loses its cartilage and its diameter can be significantly altered by the smooth muscles surrounding its walls. In response to asthma, the smooth muscle tightens. Increased secretions of mucus occurs also during the attack, and now air within the alveoli is prevented from moving. Indeed, expiration of carbon dioxide is much more effective during asthma attacks than inspiration. If the condition is not acutely reversed with the treatment of epinephrine, which relaxes the smooth muscles, the patients may die. Having discussed the microscopic anatomy of the lung, let's now get to the business at hand and present the gross anatomy of the lungs, the information relevant to a physical exam of a patient. On the upper left, I show the drawings of the two lungs, and on the lower right, I show the appearance of dissected lungs. Note that the right lung is a bit larger than the left lung. The right lung also consists of 3 lobes, the upper, middle, and lower lobes, whereas the left lung only exhibits 2, the upper and lower lobes. Each lung has an oblique fissure, and it is what separates the upper and lower lobes. The surface projections of where to detect these fissures are indicated in the slide. The right lung also exhibits a horizontal fissure that separates the upper lobe into an upper lobe proper and a middle lobe. Knowledge of the location of these fissures, vis-a-vis the ribs, allows a clinician to know precisely which lobe of each lung is being auscultated during the physical exam. For example, if you place a stethoscope above the nipple on each side of the chest, you're listening to the upper lobes of each lung. If you listen below the nipple line on the right side of the chest, you can listen to the middle lobe of the right lung. However, it is still the upper lobe of the left lung. Finally, where do you listen to hear the lower lobe? You have to go to the back of the patient to listen to their lower lobes. Although they are called the lower lobes, in reality, they project posteriorly in the patients. Try and recall during your own physicals if the physician asked you to turn so that they could listen to your lungs. They were listening to your lower lobes of each lung because it is to the back where these lobes project to the surface. The next topic we will discuss in brief is the innervation of the lungs, but first an orientation of what structures are found entering the root of the lungs. Here I show you the mediastinal surface of both lungs and again remind you that the lung is covered with a microscopic membrane known as the visceral pleura. For orientation, I now label the structures that are visible entering the root of the lung: the primary bronchus of each lung, the pulmonary arteries, and the pulmonary veins. I mentioned previously that the visceral pleura receives no somatic innervation. That is, you cannot consciously feel your visceral pleura, and it follows that you too cannot consciously feel the lung tissue parenchyma. This is not to say, however, that the lungs do not receive innervation, because they do. However, all the innervation to the lung is exclusively autonomic innervation, and these nerves will arise from plexuses located near the trachea and follow along the bronchi and vessels just described into the roots of the lungs. Where do these nerves arise from, however? The autonomic innervation forming the plexuses that enter the lungs ultimately arises from two sources. Shown here is a dissection of the thorax with the left thoracic cage removed. Let me now label structures for orientation: the ascending aorta, the pulmonary trunk, and the root of the lungs. The prominent nerve running anterior to the root of the lungs is the phrenic nerve. The parasympathetic innervation to the lungs is from the vagus nerve, now labeled. Note, the corresponding vagus nerve runs posterior to the root of the lung. The phrenic nerve runs anterior to the root of the lung. The sympathetic innervation of the lungs will arise from the sympathetic trunks. The vagus nerve will constrict the bronchioles. The sympathetic nerves dilate the bronchioles. Hence, think of what medication one would administer to the patient suffering from asthma. The last topic to cover in this part of the lecture is radiology of the lung. The objective is not to be all-inclusive, however, merely to introduce you to the subject matter and emphasize certain features that many clinicians should be able to appreciate in a chest film. Previously, I showed this slide to introduce the appearance of the lungs as observed in a CT image. The CT represents an axial image approximately at the level of the sternal angle, and the healthy lungs are indicated by the dark area. I now label the other relevant structures that can be observed in the image: the superior vena cava, or SVC, the ascending aorta, the descending aorta, the pulmonary trunk, the right pulmonary artery, the left pulmonary artery, the trachea, and the esophagus. Stop the film if you wish and review these structures. As you gain experience in looking at CT images, recognizing the structures will become easier and easier. It is only a matter of time and effort, sort of like everything else in life. Similarly, you will need to identify the numerous structures that can be readily observed in a conventional chest radiograph. This image is labeled as a PA because the X-ray beam penetrated the patient in a posterior to anterior direction. This is the conventional way to image the chest to minimize distortion of the heart. The detector of the X-ray beam is placed close to the interior chest, and the beam diffuses less distance when the image is made in this way. Yes, there are a lot of structures here, and for anatomy, it is customary to identify all these structures in a chest film. Again, stop the film and begin to learn how to identify these structures in a film. To try and help you identify the structures, I now superimpose a drawing of the heart and great vessels on the chest radiograph. Stop the movie and go back and forth to gain a better appreciation of what can be readily identified in a conventional PA chest radiograph. The second common view of the chest is the lateral chest film, shown here in a woman. Commonly identified structures are labeled. Stop the film and make sure you're able to identify the labeled structures. Again, I have superimposed an image of the thorax content, this time a dissection, onto the film to help you see where the structures are specifically located in a patient and then give rise to the profiles on the radiograph. Don't despair now that everything looks somewhat diffuse and the structures are hard to identify. In time, you gain experience and know-how, and you will become an expert in identifying different structures in the normal and pathological chest. This now concludes the second part of the respiration subject movies. As always, I thank the cadaveric donors who made this presentation possible, but also Mr. Mark Savonia for his outstanding assistance as laboratory manager of gross anatomy. The dissection images shown here could not have been possible without his expert handling of the cadaveric preservation.